Thanks so much, Dr. Brothers, for the excellent papers. I am going to fly through my list of papers because we don't want to be late. Next session will be starting in literally 10 minutes. So again, my papers are the ones that I selected for this public, which is, in other words, for this audience, for vascular topics, but there are other very good papers at the JVIR that are non-vascular. So for those ones who don't know, vascular, JVIR basically has been published continuously since 1990. It's the journal of, official journal of SIR, of our society, peer-reviewed, and the associate editor actually is with us today, Dr. Brian Funaki. So it has one of the highest impact factors we have among all the radiology and vascular journals. There was over 1,000 submissions last year, and there's remarkable growth in the last 3 years of 40% of growth. So my first paper is the quality improvement guidelines for treatment of lower extremity deep venous thrombosis with use of endovascular thrombus removal. There are several interesting things on this paper, but I want to focus in one thing. So the question that I took from this paper, and this is something we debate very frequently, should we use filters during lower extremity DVT endovascular therapy? Should you use filter to protect when you perform thrombectomy? And basically what this paper says, and that's the consensus of the paper that represents the idea of the society, the best way to prevent procedure-associated symptomatic PE while you perform the case is to have adequate anticoagulation before, during, and after the endovascular procedure. The incidence of symptomatic PE during the pharmacologic catheter-directed therapy does not exceed to that observed in patients who received anticoagulant therapy alone. So in this case, only for infusion of lytic therapy does not have any indication to use a filter. In this study, there is and they mentioned this in the consensus, a multicenter randomized controlled trial involving almost 100 patients who received only infusion. There was no cases of infusion of lytic therapy. There's no cases of procedure-related PE. So the routine placement of IVC filters before infusion, only when we perform only infusion, either with Akos catheter or McNamara catheter, is not recommended. However, if the filter enhances safety for patients who are going to go for pharmacomechanical catheter-directed thrombolysis, in other words, using the trellis device or using the angiojet device, that's not clear. Also, the placement of a retrievable filter should be considered if the patient has a high risk for major morbidity, for example, patient who has a very low cardiac function reserve, patient who has a COPD. In those patients that any event or any minimal event of PE could trigger a cardiopulmonary collapse. And of course, if you place the filter should be removed as soon as possible. So that's my conclusion very quickly of the first paper. Second paper is something also that we encountered very frequently in our patients, which is to understand if what we do in terms of multiple angioplasties, thrombectomies, declots of the AV grafts, if those patients will develop pulmonary hypertension down the road or not. So the name of the paper is Impact on pulmonary arterial pressures after repeated endovascular thrombectomy of dialysis grafts. And what this paper showed is that there is no difference in 1 year follow-up after multiple interventions. These patients did not have any difference in pulmonary hypertension. And the only risk factors having a linear regression analysis and multivariable analysis, only heart failure, existing heart failure or COPD were statistically significant to have abnormality in the pulmonary pressure, not multiple procedures. However, the limitations of this study are only approximately half of the study participants received a 1 year follow-up. So to me, that's a big bias. The second thing is the percentage of patients with pre-existing heart or pulmonary disease was small. What I'm trying to say was not clinically significant because those patients had a good profile. But maybe if they had other comorbidities, such as COPD or cardiac dysfunction, more likely minimal PE could be clinically significant. So that can be a bias as well. And safety in the vulnerable patients required further clarification. So those more patients with comorbidities, we don't know what the impact is. The key message, however, in this study is, and that's what we try to teach our fellows, is the mechanical fragmentation, using whatever device you want to use, or aspiration catheter, should be always done before we open up the anastomosis that is stenotic. So try to have a compartmentalized, closed system. Before you open up the venous stenosis, try to remove as much clot as possible to decrease the chance to have PE. In terms of subclinical emboli, short term in this study show that there's little or no effect in pulmonary circulation. However, the long-term effect is unknown. So the follow-up is only for 1 year. And that's the conclusion of this paper. The other paper now is a contemporary systematic review and meta-analysis of early outcomes with percutaneous treatment for infrapopliteal atherosclerotic disease, so below-the-knee interventions in the arterial system. This study involved they reviewed 42 studies, 52 different treatments, arms involving over 3,500 patients. And they were treated with different stents. But the bottom line here is the technical success using below-the-knee stents was better than the other two treatments, which is atherectomy and balloon angioplasty only. The need of a stent was higher, as expected, in the group with atherectomy and group with PTA versus drug-eluting stent or just bare metal stent. The procedure dissection, as expected, was higher in the group with angioplasty, and that was statistically significant. And the primary patency through 30 days was much higher in the drug-eluting stent versus the other techniques, but very close between the bare metal and the drug-eluting stent. Of course, in 30 days only, if you have a stent, more like the stent will do better than atherectomy or angioplasty below the knee because the vessels are very small. Secondary patency was higher in the drug-eluting stent and the bare metal stent, as expected, and the target lesion revascularization through 30 days was higher in the angioplasty balloon only, as expected. The chance to have the reocclusion of the vessel will be higher with balloon angioplasty only in those small vessels. Limitations of this study: very heterogeneous patient population, heterogeneous lesions, so very tough to compare head-to-head. There's no distinction among the different atherectomy devices, so they didn't stratify the results per atherectomy device. They simply bundle all them together. And also there's only a short-term result, 30 days. In the final comments, there was an expected low incidence of dissection. They were expected to have much more dissection or occlusions, and the need to have provisional stents in the angioplastic group. And at 30 days, there was a significant better primary and secondary patency in the drug-eluting stents versus bare metal stents. And one of the things that they address in the paper that could be because of the dual antiplatelet therapy versus single in the bare metal stent. The other paper is endovascular recanalization of native chronic total occlusions in patients that had failed lower extremity bypass. This study had the purpose to to investigate feasibility, safety, and outcomes of endovascular recanalization of native chronic total occlusions in patients with failed lower extremity bypass. Basically, these involved a small number of people, just 19 patients, 18 patients, 19 limbs. But what is interesting is all of the failed bypass grafts were treated with self-expandable stents, including here several manufacturers of the laser-cut bare metal stents. Some of them had covered stents, and some other have the superior stent as well. The results: the mean patency of the failed bypass was about 27 months. All the limbs were task D, so high-grade lesions and long lesions involving the native circulation. And the technical success was pretty high, above 95%. And the mean ABI improved from 0.3 to 0.7 in the people who were treated endovascularly after failure of the bypasses. There were no major complications or emergency amputations, and the mean follow-up was pretty good, 64 weeks only. In terms of patency, There was a remarkable drop in the patency in primary and secondary in 12 months. The good thing is more than half of the limb were salvaged. There was limb salvage in more than 50% of the people, 65% in 2 years. That I think is pretty good. It's pretty remarkable if you could avoid to have a major surgery for these people or redo of the bypass. And the amputation-free survival was around 60% in 2 years. In conclusion, the endovascular recanalization of the native chronic occlusions in patients with failed lower extremity bypass is technically feasible, safe, and the results are acceptable in order to save the limbs. And last paper, this is ultrasound, ECOS, versus standard catheter, McNamara, thrombolysis in 102 patients with acute or subacute limb ischemia. This study tried to compare safety and efficacy of the McNamara versus ECOS in patients with limb ischemia, basically. They enrolled 75 patients in the group with ECOS and 27 patients in the group with McNamara. There was no difference in terms of amount of drug infused or the length of time of the drug infused. And the complications, which is interesting here, the only difference between the two groups was more bleeding, higher incidence of bleeding, statistically significant difference in the group in favor of the ECOS versus McNamara. I don't get it. I don't understand why one would be better than other in terms of bleeding, but that's the fact. One better than the other in terms of there's no difference in time of infusion, neither in dose. So the dose was the same, time of infusion was the same. So the conclusion of this paper is that both ECOS and McNamara are safe and efficient in treatment modalities for patients with acute limb ischemia. The observed lower risk of total bleeding for ECOS versus McNamara may warrant future studies, and that's the way they closed on the paper. That's it. Thank you very much.